more. Asked to start video. Yeah, okay. So welcome everyone. I think we should probably kick off. Now, I actually thought that, Norman, I thought that you had worked with Leanne and Chris Dereveke, but in fact, I think you worked with Benjamin Cody up at Giza Hospital. So you probably don't know anyone here present. No. So just by way of introduction, we've got Norman Blumenthal, who's an associate professor, I think, at the Notre Dame Catholic University, and also a clinician, busy clinician at Blacktown Hospital Norwest. And we've got Ishawri Casikar from Nepean Public Hospital. Ishawri did a recent trip to Sopas Hospital in the Highlands of PNG just before COVID closure. And Norman's done, I think, 2 trips to Giza Hospital in the Western Province, which incidentally is in lockdown at the moment with COVID, a bit like Sydney. We've got Leanne Panisi, who's the head of department, just out of screenshot. And hi Leanne.
Hi.
We've got Chris Dereveke, who's also a senior gynecologist. And then next to Chris, we've got Lenin Manabuasa, and we've got Angeline Naqu. Angeline is related to Greg Gelini? No.
Rooney Jagili.
Rooney Jagili. Yeah, Rooney Jagili. And then we've got Morris Kiko on the far left, who's a gynae registrar. So Margaret's with us from Vanuatu. Hi, Margaret.
Hello.
So Margaret, welcome, Margaret.
Hello. Hello, Margaret.
So,
hello, everyone.
So these guys all know each other, but just for Norman and Ishawri's benefit, Margaret's a senior gynecologist from Vanuatu. And apologies from PNG, the team may turn up a little bit late, they're quite busy. So tonight's topic is uterine conditions, and I'm just the Zoom facilitator. I've got nothing prepared, and it's really, I'll hand over the show to Norman and Ishawri, Margaret and Leanne and Chris, just to start off some discussion. Does anyone have anything prepared specifically? Yeah, I thought it would be better that we just have discussion. So did you want to get started, Leanne?
Thank you, Gary. Actually, in Honiara, we've got Chris in charge of the gynae ward. And Chris looks after the gynae cases in the department. I'll let him talk after this. I'm just giving a short introduction. We've got the common cases that we've got here would be uterine fibroids, bleeding uterine fibroids, patients presenting with anemia, commonly, which is one of the common admissions to our wards. We've got cases of adenomyosis, endometriosis, and cervical cancer. Most often patients present to us very late, and in late stage that they go on palliative care. In cases that we have patients who come in for pap smears, we see them earlier and we offer them hysterectomy. Those cases that come from the province who are difficult to follow up, we often offer them that. Once in a while, we get other cases like ovarian, that's more not so much as uterine, but related to uterine would be ovarian malignancies. Other times would be, I'll hand over to Chris if you could say other things, other patients that are admitted in our wards. Thank you, Chris.
Thank you, Leanne. As Leanne has alluded to, in a gynecology ward, most common uterine condition we have is fibroid or leiomyoma. It is challenging for us with regards to diagnosis and management. We have overworked medical imaging department, difficulties in clinical diagnosis as well due to cultural issues, empowerment issues of female, difficulties in early presentations. So those are the challenges in actually diagnosing uterine conditions. Fibroid is the commonest one. Treatment-wise, most of us, we just go straight for hysterectomy. As long as you have a fibroid, there's a mass growing in there, our ladies want it removed. They don't want to go home with a mass. They live far. We are limited with the hormonal and medical treatment as well. We don't have GnRH analogs. So women sometimes go home, they come back with bleeding and severe anemia. So most times they opt for early surgery to prevent further complications. Same for cervical cancer. We are limited in conditions of the cervix. Histological diagnosis, cytological diagnosis, most times challenges. Late, limited diagnostic capabilities. If they have completed their families, just take out the uterus. We are having challenges with diagnosis by the way of people. We cannot do endometrial sampling. We don't have hysteroscopic facility and capability. So most times any suspicious endometrial condition or uterine conditions, considering patient's age and childbearing capability, we just go for hysterectomy. It's a basic summary of our case. I'll leave it to the others to comment. Thank you.
Well, I mean, can I just sort of pop in there maybe just to get the discussion going? Chris, you know, fibroids is a very common condition, and you say you have difficulty in diagnosing fibroids. To me, that's the easiest diagnosis. Am I wrong? I mean, what's the difficulty in diagnosing them?
You're correct, sir. I might take back that one, but the difficulty I'm referring to is the imaging.
Right.
The imaging support. Clinically, no difficulties. But we sometimes want to have imaging support before we actually do the surgery.
Okay.
That's the difficulty I'm referring to.
Okay. So
otherwise, clinically.
So just in relation to that, I mean, we all have those problems. You have them, I have them, we all have them. In relation to the young woman, you know, if she's 25 or so, and she's got a big fibroid, and she's nulliparous, what do you do? I mean, I'll tell you what I do, but you know, what do you do?
I think that's the challenge we have here when we have young women presenting with huge fibroids, 20-week size fibroids or more, and they're nulliparous, they're single, and we're getting more of these cases now than before, and that's the challenge. When probably in Australia you could offer them something else, but in Solomon Islands it would be recurrent admissions with anemia, until such a time where they're tired of getting these recurrent admissions and then we'll end up doing a hysterectomy on them.
I mean, at what stage would you consider a myomectomy instead of a hysterectomy? I mean, do you have a rule of thumb? You know, like, you know, let's say a woman presents, say, with the 60. I understand the very big ones, Leanne, that you're talking about. They're always very difficult to manage. But let's say you have one at 14-week size, or you know, a 12-week fibroid with menorrhagia, and obviously primary infertility. What would you offer them at that stage? I mean, what about one of the registrars, Angeline? Like, what would you do? You know, let's say you're in a clinic and she's 23 years old. She's got 14-week fibroid uterus and menorrhagia.
So I haven't done much myomectomies. Most of the time it's hysterectomy. Definitely challenged with the still haven't conceiving, but for let's say option for the particular patient, my view would be the type of fibroid, maybe. Not all the, depending on the type of the fibroid, which would benefit from a myomectomy. That's not familiar and never have decided on doing a myomectomy as an option. And most of the primaries that, most of the nulliparous mothers that are patients that came, I think we just offer we just counsel patient properly on the available facility, available bed space, available support we can provide, and just offer hysterectomy. But most of them we just talk through on the we just counsel patients on likelihood of not conceiving later in life with the current fibroid, and if they opt for a hysterectomy, we just do hysterectomy.
I mean, look, just for my own interest, say, Morris, I mean, how many myomectomies have you seen in that type of situation? That because you're a registrar, aren't you?
Yes, I have seen only one myomectomy.
Right.
It was done in the DAISI team that came. Unfortunately, was not in. Did not see anyone here. We haven't done yet I haven't seen any yet that I'm involved in here, but I've only seen one, just one.
And Morris, what about you?
I haven't seen anyone.
Okay. Yeah. So Chris, I don't know. What do you think? Because the big danger for me, and I'm just thinking in your sort of situation, if you were doing a myomectomy on a young woman, I mean, there are particular problems with that in the community because you're sending them back into the community. Would you do that?
Yes. First of all, we engage them in extensive counseling, explaining all the pros and cons before we decided to do. If they agree to do, yeah, they will have accepted all the risks, and before they go through, the risk of myomectomy procedure to a total hysterectomy, they must be ready to accept it, and they are consented for that. Sometimes they want another scan just to satisfy their mind. We let them have it. We bring the partner over and we explained everything. If they agree, we do it. But they are always told the risk of converting to a hysterectomy. Sometimes they decided to wait and they never come back. So it's not a straight line for us, not a straightforward situation for us.
I suppose there's also this problem about offering these women myomectomies and then potentially them getting pregnant in the future, and then this discussion about mode of delivery. I'm very conservative. I think Dr. Blumenthal may be a little bit more adventurous, but I think if I remove a fibroid that's more than 5 centimeters, I tend to ask them to just offer them a cesarean section with their future pregnancies. And I think that might be a problem in some of your settings. Could that be a concern? But some of these ladies say, oh, well, I'm not going to have a cesarean section for my babies, or they just won't come. And then they may end up having home births and then end up with ruptured uteruses and dead babies and dead mothers and things like that. Is that a major concern?
Yes, I think that's one of the concerns that we have is that patients who have myomectomy might be lost to follow up.
Yeah.
And they get pregnant right out in the islands, and they wouldn't have any record of whatever's happening to them.
Yeah.
In Solomon Islands, we don't have a good patient record system where you can actually look back. All the records are written in the patient's card, and the patients take it with them to their homes.
Yes.
So if they lose the card, you will never know what kind of surgery they previously had.
Correct.
So that's a risk in terms of future pregnancies.
Yes.
So that's, I think, one of the fears that we have in myomectomy. So it's not a common thing that we do here. Yeah.
What did you say to that, Professor Blumenthal? Would that be a problem, or is there any sort of option out of this?
Yeah, that's why I was asking all those questions about young myomectomies, because the fear is in that community, as you say, of a ruptured uterus. But, when we have the facilities here to follow patients quite well, and we've got the backup. So I'm very happy. My sort of cutoff to do a myomectomy is when you have a uterus around about 16 weeks or so. If it's bigger than 16 or 18 weeks, then it's very difficult to do a successful myomectomy without too much blood loss.
Yeah.
If it's less than about 16 or less, then one can do a myomectomy. And as long as the cavity is not breached, as long as you don't enter the endometrial cavity, then I would be very happy to allow a trial of labor.
Okay.
But then again, it's not in the islands, it's not in the periphery, it's under close supervision. So it makes it very difficult in the islands.
Correct. Yeah.
So, I mean, the other issue that you guys have, I presume, is blood, either at the time of hysterectomy or to keep these patients going if they refuse to have a hysterectomy. How easy it is for you to get blood? Because I remember when I was there, we used to have family in the outside buildings donating blood. Is that still the case?
Yes, it's still an ongoing problem here. Difficulty with blood donors, personal donors, especially with women who have been in and out of the hospital with bleeding fibroids and recurrent anemia. The relatives grew tired of coming to donate, and then you find that you don't have any more personal donors to come. it's still a big challenge.
So do you get donors from the islands, or do you only get donors from the main island? You know, from Honiara?
From the main island. From the main island, the surrounding areas in Honiara, in Guadalcanal, the main island.
Yeah, and what's it like in Vanuatu, Margaret?
Thank you very much. Thank you for the introduction initially. In terms of uterine conditions, just a brief. Okay, I am part of the team of OBGYN team. Dr. Tony is, I think you may all have known him. He is my senior consultant here. Joined the team in last year after graduations. But yes, concerning the uterine conditions, yes, fibroid is one of the main presentation to our gynae clinics by our women, and so as endometrial cancers and cervical cancers. For our fibroids, I think the management is quite similar with what our colleagues from the Solomon Islands are doing. Because of the limited resources that we have, what we offer them is basically hysterectomy. Myomectomy is very uncommon. I think I've came across only one. The other one we had to refer to New Zealand for a myomectomy to be done, and she is one of our colleagues here. But the one that I was part of is another colleague as well, and she was also on the referral list to go to New Zealand, but then she had more bleeding. She was very anemic, and then we had to optimize her hemoglobin, and then we had to try and do a myomectomy with my senior colleagues. So again, we had to counsel the patient because she is, I think she only had one kid, and she still wants children, to have children to conceive. So we had counseled her, given her an informed consent for a plus minus. She moved the fibroid. It was a huge fundal fibroid, but then she was bleeding a lot, so we had ended up doing her hysterectomy. Yes, another challenges that we have is with our laboratory, with a blood bank. We had to ask for family members to come and donate blood every time a patient goes in for theater. So use with histology as well. So that affects us with our management, delayed management. And the other thing is our cultural issues. Most of our women here, they have herbal medication as option number one before they come to us. And then, yeah, those are the basic, the challenges that we have. And also in terms of patients with, like you said, if there's a case of myomectomy, that our challenges is the same. We are islands who are spread out. So for us to track them along, it's quite difficult. So when they come in, we had to do a proper counseling, pros and cons of surgery, and yeah, before we went on with the procedures. But so far, we hardly see any myomectomy, only one, and the other one we had to send overseas. But I know maybe my senior colleagues have seen or done some, which if they're present tonight, they can enlighten us more on that.
Norman, can I ask a stupid question? Because I'm a surgeon, not a gynecologist. It seems that the risk of uterine rupture post-myomectomy is the obstetric concern, and loss of pregnancy if someone has a large fibroid and they go on to have a pregnancy. Is that the issue?
So
A miscarriage?
No, I think, sorry, I just to repeat the question again.
So post-myomectomy, particularly if large, there's a risk of uterine rupture during labour. Whereas if they go on to have a pregnancy with a big fibroid, there's a risk of miscarriage. Is that right?
Yes, because I think there's two separate issues, and I mean I know it doesn't apply in the situation on the islands, but you know, if a patient comes to me, for example, with a 10, 12, 14-week fibroid uterus, and the cavity, the endometrial cavity, is assessed by ultrasound, and I know Chris says it's very difficult to get ultrasounds, but if the cavity is clear and there's no fibroids there, even if they're bleeding heavily, I would allow them to try for a pregnancy once or twice. They may miscarry, and if the pregnancies don't continue, then I would proceed to a myomectomy afterwards. But there's far less harm caused to a pregnancy by having the fibroid intact in situ. So, you know, I've seen cases where they're 14-week fibroid uteruses, 16-week fibroid uteruses that still are able to manage a normal pregnancy. So they may miscarry, as you say, number one, in the early pregnancy. They may go into premature labor later in the pregnancy. Access for delivery may also be an issue depending where the fibroid is. You know, whether they can have a vaginal delivery or cesarean or a classical cesarean, but those are sort of separate issues. So I hope that answers your question, Gary. You know, so
yeah, no, that's good. And the other thing is, I've heard of you know, ablation of the uterine artery. Is ligation of the uterine artery, bilateral ligation, is that a possible way of treating? I mean, this might be ridiculous, but I thought if we can do it by coiling an artery, could Leeanne, you know, treat a fibroid by ligating both uterine arteries?
Well, I'm sure everyone will know that, but sorry, someone was going to say something. I don't want to take the floor. Margaret?
No, carry on.
No, go on. No, you go ahead, Ishawri.
No, you carry on.
Ishawri,
What's your version?
Let's hear your opinion. Yeah.
No, I think that ligating bilateral uterine arteries just indiscriminately, I don't think is a good thing. I think certainly we do a lot more sort of advanced imaging and, you know, targeting, you know, the blood supply of the myoma and, you know, targeting those things and doing, and, you know, uterine artery and, you know, ablation that way. But I have never seen anyone doing bilateral uterine artery, you know, ligations for treatment of myomas, and certainly haven't seen it here. But maybe Professor Blumenthal has had some experience doing it elsewhere, but I haven't seen it being done here. Have you?
No, I mean,
No.
They'll develop a collateral blood supply.
Yeah.
So there's really no point in doing that. And then the only way you can do it is by an open laparotomy. So you got a laparotomy, and you know, not a good idea, I don't think.
Yeah, exactly. I think it's quite complex trying to sort of get this big bulky uterus, trying to then come down, you know, trying to sort of look at the, you know, all the way down to the insert, you know, the level of the uterine artery, and then dissecting and making sure that we don't clip off the ureters in the meanwhile, and then trying to ligate the uterine arteries. I think it's quite difficult, I would have thought.
Okay,
Isn't
so
it? Yeah,
it's
quite tricky.
I accept that was a very dumb question.
No.
Let's move on to the next subject.
Made me think, but I was like,
it's not
okay.
because, no, it's actually not, because as Ishawri said, you know, in some cultural groups, even in Australia, they don't want hysterectomies.
Yeah.
Whether they've completed or have not completed their families. They don't want hysterectomies, and we send them to the interventional radiologists who embolize the uterine arteries. So it's sort of slightly different to what you're saying. We don't go in and do an open uterine artery ligation, but it's done with the interventional radiologists who send up a cannula right through into the uterine arteries. They put in the embolization pellets, and it blocks the uterine arteries, so the fibroids shrink. And usually you get about a 50% shrinkage. And so it just decreases the size of the fibroids, but doesn't necessarily decrease the amount of bleeding. and there's still a big bulk in the abdominal cavity. And I've found that in about 40 or so % of patients who have that embolization, those necrotic fibroids become infected.
Yeah.
And then they land up with a hysterectomy at the end of the day in any case. But it is certainly being done, and it's being done relatively frequently in Sydney with many cultural groups who don't want hysterectomy.
Yeah. I mean, we did have one terrible complication with it at Nepean Hospital. This lady actually had part of her buttocks sloughed off because they didn't embolize the correct vessels. So I think it went into inferior gluteal artery or something. So, it's not an intervention that we would take, do sort of willingly to most women unless that's really what they're requesting. But as Professor Blumenthal said, you would still have to go back in at some point and try and do a hysterectomy on this debulked uterus. So it still can be quite difficult, I think. Yeah. Mm.
And I mean, the other issue, Chris and Leeanne, is if you comment on, because you've got these very large fibroids, and is there anything, and you see them probably more than we do, but is there any clinical feature that you can determine that where you can exclude a sarcoma? Because that's one of the big issues that you have. And do you have any statistics on that?
So far, the sarcoma we have diagnosed are diagnosed retrospectively after we have removed the fibrotic mass. Sometimes we suspect, but confirmation comes after the histology.
Yeah.
And we have been seeing some sarcoma cases increasing in number lately. So our direction will be to try and see the common clinical features of those cases retrospectively and then move on from there. Otherwise, we treat them all as fibroid at the beginning.
But sarcomas are notoriously difficult to diagnose, aren't they? You send them off even for a really good quality ultrasound scan. And then, just because it has increased vascularity or it suddenly sort of seems to be appearing to grow in size, it doesn't necessarily mean that it's a sarcoma. I mean, we've had sarcomas of 2.5 centimeter size fibroids, not necessarily the really big ones. And, that we never picked up on an ultrasound scan until I started doing the laparoscopic hysterectomy. And as soon as I tried to move the uterus away, that fibroid just crumbled into a mass. And I was like, oh God, this is not normal. Because, just manipulating the uterus around shouldn't actually cause that fibroid to just disintegrate. And that lady did have a uterine sarcoma. It was a 2.5 centimeter fibroid in a young lady who was like 45. And we were just doing a hysterectomy because she just had prolonged menstrual bleeding. So I think they are very difficult to diagnose, aren't they? There really is not a lot of criteria for diagnosis of sarcomas. I think even we struggle with it, don't we?
Absolutely.
Mm. Yeah. Yeah. Well, who knows?
Can I just ask, is there a role for a Mirena, an intrauterine device for heavy bleeding when there's a fibroid?
I'd be interested to hear if they have Mirenas. Do you have any Mirenas there?
We don't have Mirena as a regular supply, but we get donated ones. Right. When the overseas team come, they usually bring some, but it's not readily available.
Right. So, so Lenin, tell us, what would you put in a Mirena?
It's for fibroid.
If a patient comes in with heavy bleeding, yeah.
Yes, so it's another option where we can use. to insert a Mirena to control bleeding as well as to reduce the size of the fibroid.
Okay, I see Morris is gone. I wanted to see what he said, but he disappeared.
Morris, come back.
Come back. We want to hear what you want to say.
I think he's coughing. Maybe Angeline can give her opinion.
All right. What do you think, Angeline? Would you put in Marina?
I think in case of if the patient does not opt for an operation, I wouldn't mind try, just a try and see if it improves.
Yeah. Okay, well, I mean, it's very debatable, and I'd be interested to hear what Ishawri and Sean have to say. But generally, I think if a uterus is above about 12 or at the very, very most 14 centimeters, and it's got irregular fibroids, then it's very, very unlikely going to help the menorrhagia.
Yeah.
And not only that, it's going to cause irregular bleeding. So they're going to get heavy bleeding and intermenstrual bleeding. So I've always found that, and that's why I asked the registrars, because it's interesting that you'll learn with time that it's almost a contraindication, you know, to putting in a Marina when they're fibroids.
Yeah, I think, you know, definitely, I think if the uterine cavity on ultrasound scan is more than 10 centimeters, because that Marina comes in at 10 centimeters, and I've always found that if I'm actually having to pull that thing, you know, that little dowel down beyond that 10 centimeter mark, I just think that, you know, that I don't think the Marina was actually designed to be in a uterine cavity more than 10 centimeters. And whenever I've ever put a Marina into a woman, even if it's just an intramural fibroid, if the cavity is more than 10 centimeters, it has never worked properly. As Professor Blumenthal said, it actually causes a lot of intermenstrual bleeding. It takes several months for them to actually, you know, get any sort of response from it. And then by the time they come for their 3 or 4 monthly check, they're just like frustrated with it. And then we've come down to the, you know, discussion of having a hysterectomy anyway. So I think the large uterine cavities, the ones which are where the cavity is distorted, especially with the submucosal fibroid, the Marina I have found is really not very suitable. For a smaller cavity with a smaller intramural fibroid, I think it's worth a try, but I still wouldn't offer a Marina for someone with a cavity length of more than 10. I've just found in my experience, it hasn't actually worked very well. Or even an endometrial ablation, you know, we have the NovaSure or the Caviterm endometrial ablation techniques. Even that doesn't work, in my opinion, for a cavity that's more than 6.5 or 7 centimeters. It just doesn't seem to work very well. So I think bigger the uterus, larger the fibroids, you know, hormonal treatment, I think, does not actually work well.
Yeah, I agree with that, Ishi, I think, and Professor Blumenthal, I think that I think that the hormonal effect is overtaken by a structural effect at some point, and I think that's probably about the point, maybe around 10 centimeters or 12. But I found high dose progesterone still useful for menorrhagia even with large fibroids, but and that might be something that's available, but obviously it's not going to help with fertility, which I think you guys were touching on earlier. But have you sort of had any? I mean, we certainly use it in large endometrial cancer tumors that are palliative here. So I presume we could use it with larger sort of benign fibroids.
Okay, well, just I'll try and run through this quickly, but just coincidentally, during the last 2 weeks or so, I've seen this patient. So tell me if anybody can advise me what to do with her. So she's about 52. So she's 52 years old. She's got 2 children, normal vaginal deliveries. And she, about 3 or 4 years ago, she had an unprovoked DVT. Okay, so, and that was treated, and then she went off medication. Then about 3 months ago, she developed breast cancer. So she's now got breast cancer. she's got 80% estrogen receptor positive and 90% progesterone receptor positive. So Sean, there goes your suggestion for me. So we can't use estrogen, we can't use progesterone. So I was away about 2 or 3 weeks ago before the lockdown for a week, and she came in and my locum, she had a hemoglobin of 74. So I know, Chris, you probably 74 is very high for you, but you know, a patient over here has a hemoglobin of 74. You know, everyone gets a bit worried. So you know, so my locum gave her 2 units of blood, and she did a curettage and found proliferative endometrium. Again, so her hemoglobin I saw a few days ago is now about hemoglobin 103, 104, but she's still bleeding. And she's got her, sorry, the most important thing I have to tell you, she's got a uterus that's about 14 centimeters in size, which seems partly fibroid and partially adenomyotic. So she's got, and she delivered a second DVT after the curette 3 or 4 weeks ago. So she's had 2 DVTs. She's got estrogen and progesterone positive breast tumor, and she's got menorrhagia. Anybody want to give me a suggestion for treatment?
What is she on for contraception?
She's 52, 53, so they use barrier methods.
Okay. I think I would offer her a definitive procedure. You know, once she gets to about 6 weeks after this DVT, I would actually offer her a hysterectomy. I know it's high risk and everything, but if she's still got proliferative endometrium, she's still menstruating, I think any procedure that you do, even an endometrial ablation, may or may not work with that sort of size of uterine cavity. And I think I would take my chances and offer her a hysterectomy.
Right.
Heart in hands, but I would. Yes.
What do you guys think, Chris? Margaret?
I'm thinking of a context here. I'm thinking about your case in relation to a context here.
Yeah.
We will offer her hysterectomy after we have stabilized all her comorbidities. Yeah, comorbidities and everything is stable, and we'll go for hysterectomy.
In spite of a DVT, after both, one spontaneous and one following a curette.
Yeah. We'll make sure that it's sorted out.
Okay.
Yeah, with the interdisciplinary team. And once that is controlled or relatively safe for hysterectomy, we'll go for hysterectomy. But that will be our aim for hysterectomy.
And Margaret? Margaret, what would you do out there?
I think in Vanuatu, it would probably the same.
Yeah.
With our issues of challenges with blood bank and all, we would try and optimize her hemoglobin, and then maybe on the way get the anesthetist or medical team, a multidisciplinary approach, and then plan for a definitive treatment would be just the hysterectomy and now setting. Yeah.
Anybody, Sean?
Oh, I was thinking you guys would say, what's wrong with an HB of 77?
Yeah.
That's what I thought you'd say. Which is fair enough. But no, I don't know. Yeah, that's a tough one. Sounds like she's going to get a DVT if you do a minor or a major procedure. So I guess I'd go for the major. I was thinking maybe you could get away with some kind of you could do a rollerball or something that's going to be annoying and it might not work. And she's probably going to get a DVT anyway. So I guess you, and then you have to, I don't know, in terms of your bridging issues, perioperative anticoagulation issues, you just do what you can in consultation with heme, I guess. You'd sort of stop them 24 hours before with the Clexane. Maybe that would be enough. And then start them again the next day.
Or start it on heparin or something that you can reverse if there's a problem.
Yeah.
Well, there's obviously different opinions, yeah. But what I thought, just to give you my opinion, I wanted to do as little as possible and as short a procedure as possible, because even if things go wrong, at least we've done a shorter procedure. And she's 53, so she's bound to have the menopause soon. So I'm really trying to get her over that line. So I've taken a different approach. I've suggested we do an ablation for her.
Okay, what sort of ablation?
Well, I'll get in there and have a look, but I think we probably do. These actual resections are quite difficult when the uteri are that big.
Mm.
You know, if the uterus gets to more than about 12 centimeters, then the resection becomes quite difficult. So it's probably going to be easier to do like a Novasure ablation.
Okay.
And it's
but isn't that Novasure good like for 6.5 centimeter size cavities?
I think
it still work for bigger ones because the cervix could be larger. Yeah.
Correct. It may not work well, but all I want to do is reduce her bleeding to a tolerable level for a year or two until she goes through the menopause, not to cause, complete amenorrhea.
Yeah.
That was my approach, but, rightly or wrongly.
Also good. Mm.
Yeah. All right. So we seem as though we've exhausted fibroids, haven't we?
Can I just ask, what's a Novasure? Is that a expensive device that may not be available?
Sorry, yes, it won't be. Yeah, it won't be there. Yeah.
So how easy is it to do a myomectomy with standard instruments? Because I've seen a lot of them, well, not a lot of them, I've seen a few of them require large blood transfusions with all the clever gadgets and that we have here.
One thing, Gary, that should be probably available locally is vasopressin. And so I would say with standard instruments and vasopressin, it's a safe and reasonable option in the case of a fibroid with heavy menorrhagia or something like that in the local setting.
So with just say a 8 centimeter fibroid, you're going to do a myomectomy. What sort of estimated average blood loss would they have? Are we talking sort of
400 mils with vasopressin? I would say would probably be an average, or maybe even a high estimate. I don't know.
Okay.
Yeah, I would say about 300, 400 mils. Yeah.
Do you guys use vasopressin there with any sort of uterine procedures, myomectomies, or anything like that?
We talked about tranexamic acid last session, and that's sometimes available.
That's a good option.
Mm-hmm.
I think that's all good, for immediate blood loss, Gary. But for the people who've done myomectomies, I mean, one of the biggest problems is almost not intraoperative blood loss, but it's post-operative blood loss, because when the vasopressin's worn off, then there's that's why I tend not to use vasopressin, because it gives you the wrong impression of blood loss. So, but they tend to ooze quite a bit afterwards. So you can almost double the blood loss afterwards. So if you're going to lose 300 or 400 mils intraoperatively, you can bet your bottom dollar there's going to be another 300 or 400 mils post-operatively in a drain.
There you go.
Okay, so
sorry, so I have to qualify that. You asked about a 4 or 5 centimeter or 6 centimeter fibroid, not with that. I'm talking about the heavy blood loss when you're dealing with 14-week fibroid uteri or 16-week with a much larger fibroids. Single small fibroid of 4 or 5 centimeters, nothing will happen.
So would I be correct in saying that the management for the nulliparous woman with a large fibroid, in a woman who wants to have kids, wants to preserve her fertility, is a really tricky situation in Vanuatu and the Solomon Islands, where blood transfusions are not readily available. They don't have the gadget that you mentioned. And I guess the other question is, what is the learning curve associated with myomectomy? Is it a technically challenging or difficult operation to learn?
I think it's like most things, but in my opinion, well, I don't know. Maybe ask Ishawri and Sean just to see what they think. I'll give you my opinion maybe last.
Okay, Sean, carry on.
I think you guys are all very well capable of learning that procedure and doing it safely in the local settings. I think I would say it's less. I'd say it's less challenging than learning how to do an open hysterectomy.
Yeah, I'd agree with that. You know, I think it's a relatively simple procedure. Not simple, but relatively. The learning curve is not steep at all.
Yeah, that's right. I think if you're a good open surgeon, I don't think learning to do a myomectomy could be that difficult. Yeah.
You know, so I think, you know, from what Angeline was saying and what Chris is saying, the fibroids are too large to do a myomectomy, and the patients don't want hysterectomies until don't want anything done until it's too large to even do a myomectomy, because there is a limit to the size where one can do a myomectomy. So, you know, the rule of thumb that I use, if a uterus is bigger than about 16 to 18 weeks, you're very unlikely to get a successful myomectomy out of that patient. Of course, depending on the position of the fibroid, etc., but that's just the rule of thumb.
I think that's a fair comment, though, Gary. Like, I think that nullets with fibroids with primary or secondary infertility thought to be related to the fibroid is a difficult problem in the local setting. We don't really. I didn't catch the full meeting, but I don't know if we've offered any useful suggestions to manage that issue. But I sort of can't really come up with any. Can you, Professor Blumenthal or Ishi, did you think of anything to sort of help that's locally applicable?
I mean, you know, it's a big cultural thing, because I think that's really the problem. You know, they don't present early; they present late with the enlarged fibroids, and they're scared to have any myomectomy for fear of landing up with a hysterectomy. So, yeah, I can hear what Chris is saying. It's absolutely without the backup of blood transfusions, without the backup of the hospitals, vaginal birth. You may have not heard that earlier on, but they were worried about sending patients back into the community and having vaginal births after the myomectomies. So it's a difficult problem to manage, very difficult. Gary,
it sounds to me like there's opportunity here. It's a procedure that is not really done very often in the Solomon Islands or Vanuatu. And from what I gather, you're better off treating these with a myomectomy when they're medium size rather than large, which lends itself well to learning how to do this technique. And the risk of rupture during pregnancy when you do after a small myomectomy is, I guess, reduced compared to a large myomectomy.
Correct.
Yeah.
Yeah.
So,
I mean, just from my non-gynecological perspective, it seems like, you know, perhaps, Norman, if you were to go over and go through some myomectomies, this might be a useful exercise.
As long as we've got the blood to, you know, that we need during the procedures, that's possible. Yeah. Yeah, but you're right. That would be a good opportunity, especially, you know, that you know, Morris and Lenin haven't seen many, and Angeline haven't seen too many myomectomies.
So, Leeanne, you've been very quiet. We've got 10 minutes left. Did you want to?
Yes.
Want to say anything?
I've been listening. We've got an interesting case here that Chris would like to share and get your opinion on how to manage this case. It's actually a molar pregnancy. It's still something to do with the uterus. So I'll let Chris share the case and we'll get your opinion on this case. Thank you.
Okay, thank you, Leanne. This patient is a 49-year-old patient with 4 vaginal birth, 4 child vaginal birth, referred from one of the provinces with a approximately 20-week size uterine growth. That's the brief summary of her scan. The vaginal examination and pelvic examination, the cervix is normal, adnexus are normal, the uterus is around 20-week size, bogey, ultrasound imaging suggestive of vesicles inside, query molar pregnancies. Due to our local situation of follow-up, etc., since they come from the provinces, they agreed for a hysterectomy. Everything seems to be on track until patient is on the table under GA and suffered what appeared to be a cardiac arrest. Right now, the patient is still in gynae ward. She is around 6 weeks post-event. Our medical team have reviewed her, have started her on some treatment. Our issue now is we are waiting for at least 2 more months before we can attempt any form of curettage or hysterectomy, according to the advice from the medical team and the anesthetic team. So we are in a kind of fix here. Can we offer her some other medical or hormonal treatment while we wait for 2 months? That's our issue. Or we wait for 2 months and then we'll decide if we can curate the uterus or do a hysterectomy.
Yeah, that can only happen in Honiara, hey? Obviously the gynae issues I think are important to manage, but do they have a diagnosis of the medical issues?
The working diagnosis, according to the medical, is a heart attack or a cardiac event. She's got increased cardiac enzymes with ECG changes.
Right. Okay.
And they had to do a CPR on her.
Right. So what I was really asking is because there's no metastatic disease. The lungs are clear. Is that right?
Yes.
Yeah.
No metastatic disease.
Yeah. Not sure.
Is there any chance of her getting a spinal so you can do a D&C or something like that to get it done sooner?
We have discussed the options with the anesthetic team, anesthetic doctors, and they reckon that it's too risky for her to have a spinal and have a curate because they're worried about the blood loss in relation to the cardiac reserve and output. So they think it's much safer to do a hysterectomy than a curettage, a suction curettage. That's the advice. So we are blocked there.
Do you have quantitative beta HCG levels?
We are still waiting the results sent to Brisbane.
Okay. Well, you've stumped the panel.
I know.
I don't know what I would do.
It's like a time bomb waiting for, just hope she doesn't bleed on us. We need to be taken to theater or anything like that.
We are wondering in desperation sake, will we give methotrexate, is it advisable or just for?
Well, methotrexate
just
could be
thinking
used, but with such a large uterus at 20 weeks, I mean, it's probably going to continue enlarging if you're waiting another 3 or 4 weeks. I don't know what size it will be in a month's time. Yeah. Look, I think I doubt it, methotrexate would be of any help. That's my gut feel.
Yeah.
Ishawri, what do you reckon?
No, I think I don't think I've ever seen a molar pregnancy with a 20-week size uterus. I think that sounds horrific. But I also don't think methotrexate is actually going to touch her. I think Sean's idea about trying to evacuate, doing a suction curette on the spinal would have been a sensible decision. But I think certainly some histological diagnosis is necessary. But I suppose if they've got no other option, then, they may have to just take their chances and, offer her a hysterectomy when they can. But who knows whether at that time, whether there's going to be some sort of metastatic process already. But the longer they wait, the higher the chance of that happening, I would have thought.
After they reviews the application, is it finished? Or is there another committee?
Are you guys doing any hysterectomies under spinals?
Sorry?
Are you guys doing any hysterectomies under spinals?
Yes. Yeah. It's common for us. We do hysterectomies under spinals. We are actually itching to do the hysterectomy, but it's the anesthetic team that we have to take their opinion and their advice into account.
Do you guys do uterine artery ligations and that sort of thing? Internal iliac artery ligations, any of that sort of stuff, so you can try to minimize the blood loss if you're doing a hysterectomy? I don't know if you'd be able to reassure anesthetics about blood loss that way. I'm not sure.
So I think there's less bleeding for us to do the hysterectomy than to do the suction curettage.
Yeah,
fair enough.
We would expect more bleeding with the suction and less bleeding with the hysterectomy.
Yeah.
So we're opting to go for hysterectomy rather than curettage for her.
Yeah, fair enough.
And the fact that she comes from the province is another reason why we want to do a hysterectomy.
Yeah. Yeah, fair enough.
All right.
Your hands are tied. I mean, you have to be guided by the anaesthetist and the cardiologist.
That's right.
Yeah.
Alrighty, everyone. I think I'm mindful of the fact that it's just turned 6 p.m. here in Australia, and time's up. I want to thank everyone, the panel, Norman Blumenthal, Leeanne Panisi, Chris Dereveke, Ishawri Casikar, Sean as well, and Margaret, who had a poor reception in Vanuatu, so unfortunately had to leave early. And also special thanks to our registrars, Morris Kiko, Lenin Manabuasa, and Angeline Naqu. So the next session will be Tuesday, the 19th of October, the same time, and it will be on ovarian pathology. So be grateful, particularly the registrars, if you could start thinking of cases to present or discuss. And the expert panel will include Benjamin Cody, Yuting Huang, and Peter Bell. Peter Bell's from Westmead Public Hospital. Yuting Huang, I think Yuting may be fairly junior, Sean. You correct me if I'm wrong.
No, she's a France cog. I think she's in WA now, and she's about a year or two out.
Okay.
And I think she did gynae for a little while, so that'll be useful for the ovarian pathology.
All right, so a fairly junior panel apart from Peter Bell, who's quite senior. So obviously, Leanne, Chris, if you're able to attend and provide your input, that would be useful. Okay, thank you, everyone. Any questions at all? No? Okay. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thank you. Bye-bye.